Good evening, everyone. My name is Ben, and I'd like to thank everyone for coming along tonight. Um, we are here tonight for a very exciting webinar, and a webinar specifically for World Arthritis Day. And we're very lucky to have Professor Catherine Hill along with us, and I'll get into a little bit more about Catherine in a moment. First and foremost, I'd like to say that both me and Catherine present from Ghana land today, and I'd like to pay my respects to elders past, present, and emerging. This webinar has also been made possible through funding from the Country South Australia Primary Health Network. Now, for those who haven't met Catherine, aren't aware of her, she's actually our medical director here at Arthritis, and she's a clinical rheumatologist and epidemiologist who really specialises in evidence-based healthcare. Professor Hill is currently the head of rheumatology at the Queen Elizabeth Hospital, and she's a clinical professor at the University of Adelaide. Now, Catherine also leads the Rheumatology Research Group at the Basil Hetzel Institute with research expertise into epidemiology, clinical trials, and biobanking. There's a lot of different things I could highlight of Catherine's achievements, but the ones I've got for tonight is that she's the chair of the Education Committee of the Australia Pacific League Against Rheumatism. She's a board member of the Australian and New Zealand Vasculitis Society, and she's also the Hospital Research Foundation Group board member. And then she's also a past president of the Australian Rheumatology Association and a previous member of the Pharmaceutical Benefits Advisory Committee. So we've had a few questions, but Catherine's going to start tonight with just kind of going on over a little bit about arthritis and rheumatism, and then highlighting some research projects across the state too. So I'll hand over to you, Catherine.
Thanks so much, Ben, for inviting me to talk on what's a really auspicious day, World Arthritis Day, a really good day to highlight arthritis in Australia. And as you can see here, it affects 1 in 7 Australians. This is from the recent government data. But really, I think it probably affects more than this number of people, because I think there's a lot of undiagnosed arthritis in the community. It's the second most common long-term health condition, and also the second most common reason why people have early retirement due to ill health. There's over 100 forms of arthritis, and the Hospital Research Foundation Group Arthritis is here to help any South Australian with any type of arthritis. And I really encourage you to either visit our website or call our free information line. The number's there, and it's open 9 to 5, and we've got 2 wonderful health educators who can answer your questions and direct you. What I'm going to do tonight before we go to the question and answers is I'm just going to highlight some of the research that's going on around Adelaide in this. It's certainly not every bit of arthritis research that's going on, but I'd just like to highlight a few of them. This is the A3BC. It's the Australian Arthritis and Autoimmune Biobank. It's an Australian-wide biobank and an information resource for research for inflammatory arthritis, rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and vasculitis. And it basically recruits people with those conditions. We ask people to fill in some questionnaires and, if possible, give some blood. And the idea is that we are looking particularly at causes of early development of disease, better treatments, earlier detection, and hopefully a cure. It's an Australia-wide endeavour, but there's 3 places in Adelaide, the Royal Adelaide, Flinders Medical Centre, and my department at the Queen Elizabeth, and we're the hub for Australia. But the idea is we're going to get a national database to get as much information. So if you're interested in contributing to the A3BC, you can get in touch with us. But at the end of today, if you're interested in any of the studies, you'll be able to have the opportunity to leave your name, and Ben can forward those to the relevant researchers. That's right, Ben, isn't it?
Yep, absolutely. So at the end, there's a little feedback form for everyone that should pop up immediately. And then in that feedback form, if you include your email, we'll be able to mail out to you and pass those on.
The Prospect trial is one that's is part of the A3BC. And what we're doing is we're recruiting patients who've been doing really well on their biologic drugs, and working with clinicians and scientists to better predict when and how these drugs can be reduced or stopped, to minimise side effects and costs, and to maximise drug-free remission and quality of life. So if you're someone with rheumatoid arthritis or psoriatic arthritis and you've been stable for a long time on your biologic medication and you've been thinking about whether you'd be able to decrease your medication, then you can consult with your rheumatologist or contact us directly about being part of that study. It's going to be really important in the future because we're hoping from this study we'll be able to work out the best way, the people who can reduce their medication, which unfortunately won't be everybody, but also help predict those who can, and also the best way to reduce the medication. Our colleagues at Uni SA, Felicity Braithwaite and Natasha Stanton, have developed an educational video about osteoarthritis, and they'd really love some feedback about this. Study involves having a look at the video and giving them some feedback on an online survey, and hoping that you'll be able to help them improve the video. And it's for people with or without knee pain and with or without osteoarthritis are eligible to participate. So they'd love to hear from you. For patients with fibromyalgia, as well as people who actually don't have pain, the group at Uni SA, the pain group, are also interested in finding out how chronic pain influences our decision making. We all know how having pain does influence that, but they want to find out how chronic pain does, and they're paying people to be part of a short experiment. If you've got chronic pain, if you're interested in this study, mention that at the end, and we'll be able to direct you to that group, or there's a web link there. At the Queen Elizabeth, we have a registry for giant cell arteritis. You might not have heard of this. It's quite a rare illness, but it does affect mainly older people, and it's caused by inflammation in the blood vessels. We started this registry to try and collect data about people with this rare disease to help with better treatment, earlier detection, and better quality of life. It involves a single blood test and then filling in some questionnaires. So if you have this illness, or you know anyone who has, we'd really love to hear from you. And our most recent study is one called the Sterling PMR study. Polymyalgia rheumatica is a form of arthritis that affects mainly older people and can cause a lot of debilitating pain, particularly around the hips and shoulders, and it's treated with prednisolone. The problem is often people can't get off this prednisolone. Prednisolone is a form of steroids. So this study, which is being conducted in the UK and Australia, is trying to find out if further medications can help polymyalgia rheumatica. And this is actually funded by the National Health and Medical Research Council, and also by the equivalent in the UK. And South Australia is the Australian hub for this study. And if you have PMR and are having trouble getting off your prednisolone, or someone who has, please be in touch, as we'll be starting the study in November. And that's just a short wrap up. There's plenty more studies going on, and often those studies are actually highlighted in the Arthritis SA newsletter, so you can sign up through the website for that newsletter. Or just be in touch, because the helpline ladies often will know about studies that are coming up. So I'm going to throw back to Ben, because I think he's got some of your questions.
We do. We've had a lot of questions come in, and thank you for that update, Catherine. It's lovely, and to touch on it as well. So with all the studies and things like that, if the researchers ask us to try and help take people in, our e-news and our Facebook and things like that are really good to follow, because they'll have them. So we'll start with the questions, Catherine, if you're ready. The first one we've got comes in asking, what does the role of diet play in managing arthritis, and are dietary changes required?
On the whole, dietary, the best diet is going to be a really healthy diet. So that's one that's high in fruit and vegetables, particularly green leafy vegetables, and in fish and chicken, and lower in red meat. There's some studies that seem to show that a Mediterranean type of diet can improve some of the symptoms of arthritis. And certainly some older studies in rheumatoid arthritis also suggested a vegan and vegetarian diet may help symptoms. But there's no particular sorts of food that you should absolutely avoid in most arthritis. Some people find that some types of foods might trigger for example, their gout, which is a form of arthritis. And that would be things that are high in purines, like shellfish, Vegemite, some of those types of things. But there's certainly some really good information on the Arthritis Australia website about diet and about diet and gout.
Now, I'll do a small self plug as well, is that we had an old colleague of yours, Evangeline Mancioris, on, who did a fantastic She did a fantastic webinar earlier in the year, and we're going to have her back on next year, which really delved further deeply into that as well.
Yes.
So if you're interested in that webinar, it's up on our YouTube, or just call up the information line and they can forward that one on to you.
Yep. I forgot about that. It was great. I listened to that one myself.
The next one's an interesting one, and one that I get out in the community a little bit. It's so what are the causes of the aches of osteoarthritis, if it's specifically an osteoarthritis? And they're asking more specifically if there's no inflammation involved at that time period.
Yeah. So osteoarthritis, the hallmark symptom and sign of osteoarthritis is actually reduction in cartilage. But the conundrum is cartilage actually has very few pain fibers in it. So why do we get pain from that? What we've learnt over recent years, when we've started doing, we used to do just x-rays for osteoarthritis, but now we're starting to do, in research anyway, we've been starting to MRI scans, which can look much more closely at the tissues. If we look at the tissues underneath, we can also see that there's some lesions and there's some bruising almost in the bone underneath the cartilage. And we know that people who have more of those bone bruising actually have more pain. And bone actually has a lot of pain fibers. We also know that although osteoarthritis is not very inflammatory like rheumatoid arthritis, it is a little bit inflammatory. We know that from when we do biopsies, and that the more inflammatory it is, the more likely you are to have pain. There's a lot of research going on at the moment to try and treat those bone lesions, because we think that will help with the pain. In my unit, we've done a couple of studies trying to treat those bone lesions, but unfortunately it didn't. The drug we just tried to use didn't actually work that well.
Perfect.
But there is a lot of work going on at the moment, and certainly everyone's looking for ways to improve pain in osteoarthritis.
I guess that one for us flows on quite well. So I've amalgamated a few questions together, and a lot of people have asked about a similar product, and one that we call the elephant in the room at times. Is there any new evidence, and people asking around if it's working, or if there's any more science around it, around CBD products and cannabinoids, I've always struggled with that word, for helping with, I guess, their arthritis symptoms and their pain specifically?
Yeah, so unfortunately there's not a lot of evidence about CBD oil for osteoarthritis or other forms of arthritis. It doesn't seem to work as well for chronic pain as we would like. Certainly there does seem to be some evidence that it helps with sleep, and I think for some people, if they get a better night's sleep, certainly that makes the pain of arthritis much easier to cope with. I did notice today there was some information suggesting that overseas, they were actually recommending a lower dose of CBD oil than previously, because people have been running into issues with thyroid disease. So it'll be interesting to see whether the Therapeutic Goods Administration, the TGA, whether they make similar changes in Australia. At the moment, there's also some studies going on for CBD oil for some symptoms of scleroderma, actually. So that'll be interesting to see how that pans out. And there are some overseas studies for CBD and arthritis. So it'll be really interesting. It'll be really great to have some evidence-based data to take to patients about the use of CBD oil.
Perfect. So it's a bit of a watch this space for the time being.
Yeah, unfortunately, it'd be nice to have for a product that's been around for such a long time. It'd be nice to have some better data, but I think we will get it, especially since there's some better products on the market now.
Yeah. So from that, people are asking if there's any research on genetically targeted treatments for arthritis, depending on someone's individual DNA or their makeup.
Well, that's part of the reason why we've decided we set up the A3BC study, because we are taking DNA from patients and in blood, extracting DNA from people's blood, and then as we follow them, we'll be able to see whether there's certain markers that predict the way people respond to certain medications, or be able to better predict, which medications you're going to respond to best. At the moment, in disease like rheumatoid arthritis, we don't have any genetic based treatments, but I think that certainly will be one for the future. There's some coming through for osteoarthritis, though. So I think it's going to be a watch this space. Whoever brought that question to the table is really has got their finger on the pulse. Another way that we can try and personalize treatment is a really interesting study that Associate Professor Mihir Wechliker is running out of Flinders Medical Centre. And when he gets referred someone with newly diagnosed rheumatoid arthritis, he asked them if they'd be happy for him to take a specimen of the inside of the lining of their joint. And then he looks at that under the microscope to see which kind of chemicals and cytokines are actually causing the inflammation. And then he chooses the best, what he thinks is the best medicine for that. And then he's following those people over time to see whether he's predicted accurately. So that study's still going, and we're going to be very interested to see the results of that.
It's always amazing talking to you about the studies and your breadth of knowledge about them, that I guess even in a place like South Australia, there's such advanced research into the condition. It's always so reassuring for the future and where we're going with the treatments of it.
Well, we're a small research community in South Australia for arthritis, but we're very active. And we also got quite a broad range. We've also got, some researchers who not only do their own research, but also are doing some studies with pharmaceutical companies, which means that people can get access to drugs earlier. People like Susanna Proudman at the Royal Adelaide and Maureen Rishmuller down at the Queen Elizabeth Hospital.
Yeah, it's amazing. The next one's a bit of a broad one. It might be quite a difficult one to answer. So someone's asking, what's the best medication for osteoarthritis?
Well, probably there's no best medication for osteoarthritis. We certainly don't have a medication yet that can actually change the course of the disease in the same way we have for rheumatoid arthritis and psoriatic arthritis. So really the best treatments for osteoarthritis are really non-drug treatments. And those are things like regular exercise, physiotherapy, weight loss if you're overweight. For example, if you take a kilo off around your tummy, that actually takes 4 kilos off pressure off your knee. Studies have shown if you lose 5 kilos, you can often reduce the pain in your knees by 40%. So that's better than any medication I can give you for osteoarthritis. So with osteoarthritis, we tend to use the simple analgesics, we call them. So that's like paracetamol, Panadols. We've been trying lots of complementary medicines. Unfortunately, there's not really much around. Some people, there's certainly lots of trials in turmeric at the moment, but we did a study of fish oil and it didn't help, unfortunately. We did do a study of krill oil, which did make a bit of a difference. So that would be one thing to try. And actually, avocado extract in one study in France also did help as well, if you're thinking about on the more natural kind of complementary medicines end.
Wonderful. Thank you, Catherine. So this next question probably goes back to the pharmaceutical board day sitting on that. So someone's asking, with the Department of Health limiting the approval of biologics to 5, what would happen if a patient that's had 5 and have failed those 5?
Yeah, unfortunately, that's the rules, and you usually have to have a 5-year wait off that. And I actually, just thinking about that, I'm not sure whether it's 2 or 5 years off before you can try more. I think though, just because it doesn't, so if you've tried 5, that doesn't mean you necessarily have failed 5. So I've got to say, even if I've found a medication, if myself and a patient together have decided that a drug isn't very effective for them and we want to change, I don't often fail them. I just ask the department if I can change it. So it doesn't technically class as a fail. So even though you might have tried 5 of the biologics, you may not have necessarily failed them. That would depend on your rheumatologist, and really a good idea to talk to them about it, particularly if you're fearful about it, because I think most people don't fail 5. We change them rather than fail them.
Perfect. Sticking on the medicines ones and the biologics, someone's asking if down the line, or if you know of any that might be coming out in the future, if there's any liquid medications for juvenile arthritis or any type of arthritis that might be coming out. That might be, and they're including more of the biologics, but also the DMARDs as well, like methotrexate. So rather than the needles and non-liquid tablets, do you know of if there's any down the line they're looking into that for kids that might have swallowing problems and such?
Yes, I actually I'm actually not aware. I'm not a pediatric rheumatologist, of course, but look, I can't imagine that we won't see the new medications, the new JAK inhibitors, which are not biologics as such, but they are often used in the same setting. I can't see why those couldn't be available as liquids in the future, because swallowing tablets and injections can be really hard for smaller children. Perhaps we want to go back and, I mean, there's probably some people on here tonight who don't know what a biologic is, Ben. Maybe we might just step back. So for patients who've got an inflammatory type of arthritis, that's where you've got a lot of inflammation in the lining of your joints. And examples of that are rheumatoid arthritis or psoriatic arthritis. The first thing we treat those patients with is what we call a DMARD, a disease-modifying agent, and those are things like methotrexate or sulfasalazine, hydroxychloroquine. But if those are not working, we go to the next group of drugs called biologic drugs, and those are targeted medications that have only been available for the past 15 to 20 years, and the numbers of those are increasing rapidly, and they're much more targeted and effective medications. They're usually given as an injection, but some of them are now in tablet form as well. And they've been such a revolution for the treatment of arthritis. And through the PBS, we have really great access to those medications, amongst the best access around the world. Really, as much access as there's available in the USA or in Europe.
And for much different price points, luckily, as well, here in Australia.
Yeah.
So
that's right. Yeah, because the PBS is very good at negotiating, and we do get medicines for good prices here.
I can say back in my community pharmacy days, we saw how much they cost to actually physically get in, and we're quite lucky sometimes with the PBS for how it comes out. A couple of people have asked actually around those DMARDs specifically as well, such as methotrexate or Plaquenil and Humira. Can you comment if it's safe to take those long term?
Yes, we've got lots of data about long-term use of those. Humira is adalimumab, which is one of these new biologic agents. That's been on the market in Australia for about 20 years. And really, we were quite concerned about the safety of those medications when they came out. But we've been really, the data is better and better about the safety of those drugs like Enbrel, etanercept, adalimumab, which is also called Humira. And the same goes with methotrexate. Longer-term studies of those, patients who've been on them for 20 or 25 years, if you keep your arthritis under good control, whether it's with methotrexate or some other medication, that's going to be the best for you. They do need all of those drugs do need some sort of monitoring. So with methotrexate, that needs some regular blood tests. And also, we ask people to keep alcohol use to a minimum because it can occasionally affect the liver. Hydroxychloroquine or Plaquenil is really commonly used, but that can be used safely as well. But you do need some regular checks of your eyes through the optometrist or the ophthalmologist.
Perfect. So it's sounding fantastic, the treatment options that are available to us these days, and the safety data is there, and I guess they keep growing. So someone's asking along those lines if there's any new treatments which are coming out for the chronic inflammatory arthritis.
Yeah, there's some new drugs coming through, one called filgolimide, which is coming through the final stages of testing. And I can tell you every time I go to a meeting, there's always some new medications out. Particularly, I've got to say, for psoriatic arthritis and ankylosing spondylitis, we've seen a lot of new drugs in that area. And those drugs are often also used for psoriasis as well, the chronic scaly itchy skin condition that can go with arthritis also.
Perfect. Someone's asking if you could discuss the links, if there's any, between menopause and rheumatoid arthritis.
Yeah, so we know that rheumatoid arthritis, is more common in women, but it does affect men as well. But often it will develop before the menopause, but really any time. There doesn't seem to be a direct link between rheumatoid arthritis and menopause. There have been some links with menstruation. So women having worsening of their pain around the time of menstruation. We think that's because during menstruation, our prostaglandin levels go up, and they're actually pro-inflammatory. So they can make inflammation worse, which is why anti-inflammatories work well for rheumatoid arthritis, but they also work really well for menstrual pain as well. But the data on menopause and rheumatoid arthritis is not so clear. We do know around menopause is when women will often start to get some hand osteoarthritis, and that's when you get start to get some lumps and pain, particularly in the ends of your fingers, in the distal interphalangeal joints, which is those little end joints that we have.
Perfect. There's been a few questions specifically about hands, Catherine, and a bit of a misunderstanding of people asking for more information, with you kind of covering that exercise is one of the fantastic things to do with osteoarthritis. Are there certain types of exercises which can help with the hands, or are there, I guess, professionals that people can talk to help with those?
Yeah, so I think there's two parts of it with hand pain related to arthritis. One is not stressing your joints too much. And that's by thinking about which kind of implements you use. So there's some really great implements that you can use, which are thicker handled, particularly for things like pens or peelers. The Oxo Grips ones, which you can actually find at the supermarket, they're fantastic, because if you pincer can you see that? If you pincer there, you're actually putting quite a lot of stress, particularly on your thumb. But if you open it up, it actually reduces. And also, actually, Lynn Crosley's done a great little video about grip, about how best to uncap jars and things like that if you're having problems with your hands. That's on is that one of your YouTube?
That's one of our videos. Yep.
Yep,
yeah,
a great video.
I've
watched I've watched that and sent patients to that themselves. But the other thing is strengthening the little muscles in your hands, and that is about getting one of those soft grip balls and doing some muscle, and also just movements like this. But I think it's the other thing that can be very helpful is a splint, particularly if you've got pain around the bottom of your thumb, which is a really common place to get osteoarthritis, particularly in older women. But a splint can be really helpful. You can get some over-the-counter splints, but if those don't work for you, then it's probably worth getting a referral to a hand therapist. Some hand therapists are physiotherapists, some are occupational therapists, but these are therapists who specialize in looking after people with hand problems, and often people after they've had hand surgery. So I would really recommend getting a referral to one of those. There's quite a few experienced ones around Adelaide that you can go to, and some of them have offices in places like Gawler, so a bit closer for country people.
Perfect. Thank you, Catherine. That's fantastic advice. I'd say if anyone's interested in watching that video, it's on our YouTube channel as well. And we hope to release many more in the coming months and years, very similar ones. There's a lot in the pipeline around those daily tips around life.
Yeah. Just daily tips to make life easier for people. That what's that stuff that grip stuff? That liner. Been
grip
using
mat.
that. Sorry, what's it called?
It's grip mat.
Yeah, grip mat. That is great stuff. I use that myself because I should be stronger in my hands than I am too.
I can say that if anyone comes down to the arthritis offices, because we've got a few OTs in there, there are many places where the grip mat has made itself been stuck on, and it makes life a lot easier, I'd say, for everyone there. So we've got a few more questions, and if anyone has some, just pop them in the questions and answer box. Someone's asking, with the inflammatory types of arthritises, how bad should they let it get, or how long should they wait until they start taking medications? Should they prolong that?
Definitely not. No. So what we know from many studies is the earlier you can get your inflammatory arthritis diagnosed, and the quicker you can get on the medications, the better it will be, and the less likely you'll have lasting damage to your joints. And the other thing is the people who get on the medications earlier are less likely to need the more potent, the more hard-hitting medications. So we definitely say the quicker you can get diagnosed, the quicker you can get on medication, then the better it is. With a group of rheumatologists and people living with rheumatoid arthritis and some allied health professionals, we've been developing some clinical care standards for patients with rheumatoid arthritis. And some of the standards are around the fact that really we would like people to be seen by their rheumatologist very shortly, within 4 weeks after they're diagnosed with rheumatoid arthritis. And then 4 weeks after that, they should be starting on their medications, as you know, that would be optimal care. Because once you get on the medication, you get things under control, and then later down the track, you can be one of those people who can come to us for the prospect trial and start to wean your medication. Rheumatoid arthritis is a chronic disease, so you'll always probably need some treatment. But the idea is to get hold of the arthritis early, treat it, and then later start to wean your medication and get it down to the lowest dose that can control your arthritis.
Perfect. Thank you, Catherine. So someone's asking around that appropriate time. They're asking, is there a set or is there an appropriate amount of time to trial methotrexate for their treatment? So that might be when they, should start to be seeing effects and things like that. Yeah,
we usually say that you need to be on methotrexate for at least 12 weeks before you see effects. Some people will see it a little early, and it will also depend how long it takes you to get to the right dose. Some people need to build the dose up, and other people can start on the higher dose straight away. It'll depend on your situation and what your rheumatologist thinks is the best for you. But some people will see some benefit at earlier, 6 to 8 weeks, but most people it takes a good 12 weeks. The pharmacist actually at the Royal Adelaide are doing a study where we're giving the first few doses of methotrexate as an injection, instead of just usually how we start on tablets, to see whether that starting with a slightly higher dose as an injection, we can get people's arthritis under control a bit quicker. So we're really hoping that will work.
Perfect. Thank you, Catherine. Someone's asking, and I think you've covered it a little bit, is there any new, or maybe is there any effective non-opioid based pain relief available out there for arthritis?
Well, I think we've talked about, if we're talking about osteoarthritis, I think, they're really, apart from paracetamol, there's not probably too much else around. I think I mentioned some of the krill oil that we've tried. I'm talking about osteoarthritis. When we're talking about, but also sometimes anti-inflammatories can help for osteoarthritis, but we do need to be cautious about those, because in some patients they can cause problems like irritation of the stomach or high blood pressure. Those can also be useful in other types of arthritis which have a lot of inflammation, like rheumatoid arthritis or ankylosing spondylitis. So those are the main ones. There's not much evidence to say opioid medications actually help the pain of arthritis that much. So I try and avoid them, because you can get dependent on them, and there are other side effects from opioids as well. So we try and avoid them if we can. So why are waiting time so long to first see a rheumatologist? Well, that's because we have not enough rheumatologists in Australia. I was involved in a study where we looked to have at the workforce, and we probably have only about 50% of the number of rheumatologists that we need. And that's because, as our population gets older, we do need more rheumatologists. But also, as we've got more medications for arthritis, more people need to come and see us, and then also come and see us for a longer period of time. 30 or 40 years ago, when we didn't have much treatment, patients would come along to see a rheumatologist for a diagnosis, but they'll often be sent back to the GP for further management. Whereas now we have such great specialised treatments, people are coming along. So that means that our workload has increased a lot. But I can say that in South Australia, one of the things that the Arthritis SA advocated for before the last election was some increased training positions for rheumatologists, and we've got 2 new training positions, and that means we can train more rheumatologists in South Australia. So hopefully we will have shorter waiting times. The waiting times are really quite long. In private practice, they can be quite long, and depending on which hospital you're referred to, the waiting times are different. That said, every rheumatologist, when they get a referral, will have a look at the referral, and if they think you need to be seen urgently, we'll really endeavour to get you in as soon as possible if it's an urgent problem.
Perfect. All right. Well, thank you so much tonight, Catherine. It's always fantastic having the chance to speak to you and I guess fire off a lot of different questions from a lot of different parts about medicines and effects and things you can do. We really, really greatly appreciate your time. If there's anything else, would you like to raise tonight, Catherine?
No, what I was going to say is on Monday I was on What Ails You on ABC radio with David Bevan, and they've just asked me to come back and do that on December the 4th. So if you had some more questions, but I'd also encourage you, if you do have any questions, to contact the Arthritis Information Helpline. The nurse educators who work on there are fantastic. And look, if they have any really tricky questions, they will often drop me a line about it as well. So yeah, those are that's a great place to go, as well as the Arthritis website and the YouTube channel. Lots of information there and lots of great services that the Hospital Research Foundation Group Arthritis offer.
Perfect. Well, thank you very much for that plug at the end as well, Catherine. Really appreciate it. Thank you for everyone for coming along tonight. We appreciate taking some time out of your day. We'll have a few more webinars coming up very soon, hopefully, and then following on for next year. And hopefully we can get Catherine on again once or twice more in the future. I hope you all enjoy the rest of the night. And yeah, thank you very much for coming along.